What I'd like to do is talk about optic pathway tumors and just sort of orient you to them, how we diagnose them, how we what we do when we find them, when they need to be treated, which is the minority of cases, what we do about it, and then some new technology and new research ventures that we're involved in. So just by way of orientation, you all recognize the eyeballs. These are the nerves, the optic nerve. Anything that affects an optic nerve will only affect vision in this eye. Anything that affects, this is the optic chiasm where the nerves intermingle. Anything that affects the optic chiasm or behind it can affect vision in both eyes. So here's what a normal MRI scan of the optic pathway looks like. Nice thin optic nerves. I think it doesn't quite show as well here because of the light, but that's okay. Here is a child with tumors of both optic nerves. Here's a child with a tumor of the optic nerve pushing out the eyeball and involving the optic chiasm going back into the other nerve. And here's a child with tumors behind the optic chiasm and the optic tracts and the optic radiation. So as Dr. Beal, as you were told earlier, these are benign tumors, not cancer. They look the same under the microscope as most of the NF1 brain tumors elsewhere in the brain. It's really not entirely clear why they occur in the visual pathway. But what's really interesting, Dr. Gutman, who many of you probably know is the optic pathway guru of the world. He's found, we found it in our series, and he finds in his mice that there's a 2-to-1 female predominance, twice as common in female mice and in girls with NF1. And it probably has something to do with the immune system of the brain. The glial cells affect the growth of these tumors. And he sees this in his genetically engineered mice that he finds. I'm going to repeat, these are not malignant. These do not spread to other parts of the body. So if you take all children with NF1 when they're diagnosed and do an MRI scan, which I'm not recommending, 15% of them, 15%, will have an optic pathway tumor. Of that 15%, only about half will ever have symptoms related to that tumor. And I'm jumping ahead, but about half, only about 35, 40%, whatever, need treatment. So we do not panic if your child has an optic pathway tumor discovered. These are tumors of young children. The greatest risk period is below the age of 6. It's really the mean age is really about 3 years of age or a little younger when they present. They rarely occur in older children or adults. They can, but rarely occur. So how do they present? About 2/3 of them present with an abnormal eye exam, decreased visual acuity when they're seeing an eye doctor. But one thing, and I stress to the pediatric residents and the pediatricians who understand it, children do not complain of chronic vision loss. The example I always use is I had a patient who dropped a 5-year-old who dropped a Cheerio on the floor, and his mother noticed he's putting his eye like 1 inch from the ground to find the Cheerio. He had 2,300 vision in each eye. Kids do not complain of vision loss unless it's acute. So other things we look for on the eye exam is that pupils don't work. Decreased color vision is an early sign of an optic pathway tumor, or when the ophthalmologist just drops in the child's eye, looks in the back of the eye and can see things back there. Unfortunately, occasionally there will be kids who have tumors just in the eye socket, pushing the eyeball out fairly rapidly often. The other third or so to present with precocious puberty, the early onset of puberty. This is why pediatricians are trained to do growth charts. You've all seen them in your office, and if your doctor is not doing them, he or she is not doing a good job. The first sign you'll see is accelerated growth, not the development of breasts in girls or pubic hair in boys, The first thing is accelerated growth. Nobody should cross percentiles. Here's what a growth chart looks like in this child. After this is about the age of 4, no kid should go get higher. They should stay on their curve here. This is an early sign that something is going on off because the optic chiasm that I showed you is right next to the hypothalamus, which is the control center for the pituitary gland and the hormones. And the reason it's important to diagnose is many of the kids who have precocious puberty, they don't have problems with their vision, but precocious puberty in itself can lead to real problems. You get tall fast, that looks great. You're the bully in first grade, but then you stop growing and you're ultimately shorter than you would have been if you hadn't had precocious puberty. And we do have sort of an anti-hormone treatment to prevent that from happening, irrespective of what we're doing with the brain tumor. So this is why I preach annual eye exams are critical for all young children with NF1. I say that 8 years. I have to say in our clinic, we practice for 10 years, and they should really be seen. Now, I admit I'm being chauvinistic. I live in a big city. There are 2 big NF centers there. They should be seen by ophthalmologists who know what they're doing when it comes to NF1. You know, we practicing getting eye exams every 2 years until they're 18. That may probably be excessive because it's rare to have a tumor develop, but that's how I practice. And really, adults don't need routine eye exams unless he or she has new symptoms. And the eye exam is a complete exam. And once again, I hope I don't offend anybody. I'm not talking about going to an optician or an optometrist. I'm talking about going to a pediatric ophthalmologist, or when we get older, an adult ophthalmologist who looks at everything. And that includes having drops. If they haven't put drops in the eye, they're not doing the full eye exam that I think is critical. You'd be surprised. I could never be an ophthalmologist, a pediatric ophthalmologist. The patience that they must have is incredible because they can actually get visual acuity down to an incredibly early age. This is teler acuity testing, and what you're seeing here, they have progressively thinner lines, and from the kids' visual attention, they can determine with pretty good accuracy on your visual acuity. This is the Lee figures. So these are like for 3 to 4 year olds, where's the heart, circle, square, house. Then we're all familiar with HOTV testing. So we do very different testing at different ages. When it was just a routine exam, we do more specific testing from the studies that I'll tell you about coming up. And then we're all used to the stuff. We're all used to the Snellen chart, right? I should have said HOTV is for like 5, 6 year olds, depends upon the cognitive abilities of the child. Okay, what about that? It's common question that's what about eye exams? If all children with NF1 undergo an MRI scan when they're diagnosed, half of those tumors would never cause symptoms, and most of the symptomatic tumors, or maybe 2/3 of them, would never progress. Look at it the other way. If only children under 6 years of age were screened, optic pathway, the tumors might develop, and some of them a month after the screening. I mean, I had a paper years ago where we found 4 kids who, we did MRI scans, or actually CAT scans, and then within less than a year, they developed tumors. So my screening didn't do anything either. So I'm a big believer, and I can't say what most NF clinics do. I mean, a number of NF clinics do not do routine screening. Some do. I'm not saying it's wrong, it's just not the way I practice. But I do, if I'm talking to an audience, I generally say I don't recommend routine screening. There are exceptions. It may be that if the baby is under a year of age and the ophthalmologist can't get a good eye exam, there are some places that might routinely do an MRI scan. And I'm not saying it's wrong. I generally don't do that. So, what do we do when we find one? As I said earlier, don't had, remember what I said, that likelihood that the child is going to need treatment is not, all that high. But if the problem is, it's impossible. Yeah, I'm sure you're really enjoying the talk. I appreciate it. They're going to. It's impossible to predict in 2023 which child will have a progressive tumor when it's diagnosed. That's sort of one of the holy grails, and I'll talk about research that's ongoing about that. These tumors, when they're found, they may cause symptoms, and then they may stop causing any problems. And there are documented cases where the tumor has regressed. There are some factors that seem to predict a worse visual outcome if the eyeball is pushed out, proptosis means pushing out of the eyeball. If they're in the back of the brain, that very consistently bodes a worse visual prognosis. And if it becomes symptomatic in an older child, that also tends to bode a worse prognosis or somebody that will require treatment. Just a word to say that NF1 tumors are very different than children who don't have NF1, who have tumors. So not children who don't have NF1, these tumors are progressive. They all require some form of treatment. They have more vision loss, they have more complications. So that's another reason it's really important if your child has an NF1 associated optic pathway tumor, if you go to a center that knows what they're doing with it. We're in a much better place when I started doing this. Kids were getting way overtreated, and I'll talk about it back in the day, because things like this were not right. What do we do? Most centers do something along this way. They do MRI scans at initially 3-month intervals and then lengthen them out. We would do an eye exam every 3 months for the first year, and if they're stable, lengthen it out as well. So, who requires treatment? As I keep saying, the majority of patients don't need treatment, but we don't have enough information. We don't even have any good information on what progression means. How do you define when a child is getting worse? So I'm involved in and I'll address this later again, a multi-center study from Children's Hospital of Philadelphia, and you'll keep hearing the names Mike Fisher and Rod Avery, where we're hoping to address that, and I'll go more in detail in a little bit. When do we treat? Well, that decision is not black and white either. It's incredibly gray. Back in the day, meaning 20 years ago, the focus was on making sure the tumor doesn't grow. Well, that isn't the be all and end all. I care more about the vision. I mean, there are times when tumor growth might cause a problem, but the whole goal of the treatment, or the main goal of the treatment, is to prevent visual loss in your child. So I'll show you in a minute. So really, once again, if your child, I think I'm preaching to the choir here, I don't know who's online, but if your child has an optic pathway tumor, he or she needs to be treated at a large center like Mercy, if you're in this area, or St. Louis, Lurie in Chicago, because there are real subtleties to the decision making. I've been going off topic a little bit, but on our brain tumor board, I'm a general academic pediatrician. I'm a therapeutic nihilist. I don't like giving drugs. The oncologists tend to be, and he just left. I can insult them all I want. They tend to be much more aggressive. I mean, they have to be. We're talking about kids with brain tumors or kids with cancer. So I'm often the guy, in the past, I was the guy trying to put my foot on the brakes, saying, wait a minute. But now it's much more accepted that we're really treating the vision rather than the tumor per se. Okay, just to give you an example, this is we did a multi-center retrospective study. And I think there were 15 centers maybe. And we looked at the reasons why the tumors were treated at various different centers. And look at all the different reasons. I mean, there was some agreement. The primary reason was vision loss, but here's the primary reason was tumor growth. So there was a lot of discrepancies, but between how good academic centers were treating these kids. So as I said before, the goal of therapy is to preserve vision. And in that retrospective study, we found that visual acuity improved in 32%, at a third of the patients being treated. Visual acuity was stable in 40%, and that's good. Stability is good. But interestingly, there was a poor correlation between the MRI and the visual acuity. Some kids had got better vision where the tumor got bigger. Some kids got a bigger tumor. The tumor stabilized, but the vision got worse. So we really are in our infancy in trying to understand when we should jump into treatment. We all agree, as I said before, that tumors in the back of the brain, behind that optic chiasm where the nerves intermingle, those tend to have a worse prognosis, but it's not one thing. We look at everything. We look at the age of the patient, look at the MRI scan, we look at the visual exam. It's hard to treat somebody with normal vision to give them chemotherapy if their vision is normal. It's always a give and take. Just what are the treatment options? Surgery is not an option for preserving vision. The only reason to do surgery is if you have a big tumor in the orbit, the eye socket, and the eyeball is being pushed out, unfortunately, in a few children, and there's virtually no vision in the brain, and it's more of a cosmetic issue. So surgery is not good, and we rarely need to biopsy these tumors, in very rare occasions. And the only reason for doing a biopsy is if we think it's what we call a higher grade tumor, a more malignant tumor, and that's very rare. Although we're actually studying this right now in a multi-center way. Radiation, I have never been involved in radiation of any child with NF1 for an optic pathway tumor. We'll talk about chemotherapy in a minute. It's not necessary. And it's quite clear, sometimes you have to if it's a malignant tumor. But we do know very well that if you radiate the brain of a child with NF1, they're at risk for developing abnormal blood vessels, which may bleed, and they're at risk for developing secondary brain cancers. 5 minutes? That's all? Did you give me 30 minutes? Oh, wow. Okay. The first line treatment after 30 years has been a combination of carboplatin and Kristen. Skip that. You've heard about MEK inhibitors, selumetinib. We've talked about a lot today, and there are studies going on studying whether selumetinib is as good or better than standard treatment. It's also being used for recurrent tumors. So what do we need? What do we need? We need better standardization of indications for treatment. What does progressive disease mean? Is it a bigger tumor? Is it vision? What do we need? And then we need better methods for detecting early damage to the visual path. So a couple of things. Give me a little more than 5 minutes. I don't think I got my full 30 minutes. Oh, really? Oh, okay. I thought I talked loudly enough. So some of you may know about the DoD, Department of Defense NF Clinical Trials Consortium. Those are the sites. It has a website. You can see all the studies that are ongoing. Many of you, I bet, don't know about RAINS, response evaluation in neurofibromatosis and schwannomatosis. This is incredibly important, and they want patient involvement. The reason is Scott Plotkin and Brigitte Wiedemann, very early on when we started having treatment studies, realized, well, it's not just about whether making a tumor big or small. It's how about if you have a tumor in your arm, a plexiform neurofibroma? It's not whether it's big or small, but is your quality of life better? Is your hand function better? Is your grip strength better? So we have multiple teams looking at what the best endpoints are for therapeutic trials. I was mentioning this earlier to somebody. clinicaltrials.gov if you're ever curious what clinical trials are going on for NF1, just go to that website, type in neurofibromatosis 1, and you can see everything that's going on, and you can filter it based on whatever symptom you want. Okay, real briefly, I mentioned that there's a prospective 23-center study that we're looking to see if we can figure out what are the prognostic factors for treating visual outcome. So how can we make vision better? What can we learn from this? And then we're looking at other prognostic factors to try and assess visual acuity and radiology. How do you correlate those two? Lastly, don't put up that red card. Biomarkers of visual loss. A biomarker is a biologic marker that measures something about the patient. So are there biomarkers that can predict damage to the visual acuity long before you lose visual acuity? Going from 2020 to 2050, you've lost the game. The question is whether we can find something going on before they're 2030 or 2040. So the two I just want to briefly mention, OCT, optical coherence tomography, looks at the retina. So the back wall of the eye, and I'll show you an example. There are handheld machines that for little babies on the right, and they're the more common one that I have certainly had is, and you need a child who can sit up and cooperate, a 3 or 4-year-old. This is what it looks like. And this is the whole retinal fiber, the difference of the layers, and this is just the different cells in there. And what Dr. Avery is really nicely showing is that you can, I mean, he is not quite there yet, but I know he will show that you can detect abnormalities in the retinal nerve fiber layer before a child loses vision. And the next step will be to see if you jump in and treat at that point, can you prevent ongoing vision loss? That's that $64 question. But I want you to be aware of Rob Avery's name and of OCT. And there he is. And I talked about the questions. Finally, the other one is diffusion tensor imaging, DTI. These are looking at sort of the visual nerve pathways, the individual nerves on the MRI. And here's what it looks like when you're looking at it. And the question is whether early DTI can predict abnormalities before you're losing vision. This is actually an ancillary study to that big 23-center prospective study that I told you about. And Dr. Avery is also looking at ways of measuring it. Maybe some of you who've had plexiform neurofibromas know that we measured them previously in 2 dimensions, and that doesn't really give a good estimate of what the volume, the 3-dimensional measurement of a plexiform neurofibroma is. Any study that's studying plexiforms uses 3-dimensional imaging. And so he's doing the same thing with the optic nerves, doing volumetric analysis to see if a tumor loses volume a little bit, should you jump in before they're lost vision. So you got me. I don't know whether I didn't get red carded. Thank you very much. Time for questions?
I think you tried to answer this, but had to go fast during that part. But this is a one that came in. Are there any drugs that have been tested to prevent the formation of optic gliomas?
I hope I didn't go too fast through the whole thing. No, I mean, there is nothing that would be interesting, but no, there is no prophylactic treatment to prevent them, not as of yet. Thank you.
Thank you.